Hello, this is Dr. Brisbane, and I'm recording a instructional video on how to prepare for your transperineal prostate biopsy. So we're going to go through several different things, and I'll highlight them here. So first, we're going to talk about how to get here. So we'll talk about the location. Second, we're going to talk about what you need to do to prepare. So we'll talk about the things you do before the biopsy. Next, we'll talk about the actual biopsy itself. This is a transperineal biopsy, and we'll talk about what that means. Finally, we'll talk about the anesthesia, how we keep you comfortable, and what to expect after the biopsy. So let's get started. First, how do you get here? So the one of the common questions we have is how do you park at UCLA? And I realize it's a complicated place and there's lots of options. So this is the map that you will see of UCLA, a couple structures that you'll recognize. This is Ronald Reagan Hospital right here. The actual building you're looking for is called the Wasserman Building, and it's right next to Jules Stein, which is one of the ophthalmology buildings. There's a couple of roads here. You can see Westwood Plaza and Gailey, but there's a road that goes up and there's a turnabout that you can get dropped off here. Alternatively, you can park in parking structure 1. There's some Jules Stein parking right here. It's called JS. And then there's parking 18, which is paid parking. So the main things are one of these 3 parking spots or getting dropped off. The actual building looks something like this. So here's the roundabout where you can get dropped off. You want to find the 3rd floor. Okay, so here's the door right there. Come in, go up the elevators to the 3rd floor. All right, now that we've finished how you get here, let's talk about how you prepare for the biopsy. There's a couple of things to do and a couple of things not to worry about. So as far as the things to do, the main one is you need to make sure you upload your imaging. Most commonly, this will be an MRI, occasionally a PSMA PET CT scan. And my team can help you, but we actually need the images, not just the reports, because we go through the imaging in detail. One of the things we want to do is we want to take the ultrasound image that allows us to do the biopsy in real time and fuse that to the MRI or PSMA PET CT scan. And that helps us to do a very accurate biopsy, identifying anything that the radiologist was worried about. And occasionally we'll also need to do some biopsies called systematic biopsies around that area to determine if it is a tumor, what the extent is. And that allows us to do some things like focal therapy. So the takeaway message is we need that imaging, and we need it about a week before at the very earliest, or very latest, in order to have our radiologist take a look at it. The second thing I need you to do is stop anticoagulation. All right. In order to stop anticoagulation, these are things like warfarin or Plavix. Also, warfarin is also called Coumadin. But you need to speak with the provider who prescribed that anticoagulation. And that provider can be a cardiologist or an internal medicine doctor, but they're the ones who are going to tell you, is it safe to stop that medication for a period of time? Sometimes it is, sometimes it's not. If it's not safe to stop, that's fine. I just need to know about that. And so you and I need to have a chat about how we're going to modify the biopsy in order to do it while you're still on the anticoagulation. So it's a conversation we need to have. But go talk to the doctor who prescribed you that medication. Ask them how long we can stop the medication for. Sometimes it's 2, sometimes it's 5, but you just have to modify it specifically for that medication. Finally, I need you to sign up for My UCLA Health. And this is going to help us communicate better. So all the results from the biopsy go to this My UCLA Health website that you can log into. It's individualized to you. We can send messages back and forth in a secure type of email. And this will allow us to communicate very nicely. Finally, some of the things you don't need to worry about that are common misconceptions. So you don't need to stop eating. You don't need to fast. All right. So this procedure is done in the office. So there's no anesthesia that interferes with your airway or causes you to vomit. So that's important to remember. You don't need to fast before the procedure. So you can have lunch, breakfast, whatever you like. You don't need to do any bowel preps. These are commonly called enemas, and these are very common before a colonoscopy. It's not important for this. This is important for transrectal biopsies for a different reason, but for the transperineal biopsy, you don't need to worry about it. I just ask that you do a regular bowel movement before the biopsy as best as you can. The third thing is you don't need to take antibiotics. This is also something that is done for transrectal biopsy. We're going to use a transperineal technique. And so, because it's a sterile procedure, you don't need the antibiotics. There's a couple of places where I might change that for people who have had a kidney or a lung transplant or recent hardware implants, but the vast majority of patients don't need any antibiotics. All right. We're cruising along. Let's talk about the actual biopsy. And as I mentioned, I would like to do this in a transperineal fashion. Okay. So this is the sagittal view of an MRI. It's one of my patients. And we're looking at you. It's as if we opened you through the nose like a book, and then we're looking at you from the side. So I'm going to draw a couple of pieces of anatomy. First, you'll see the bladder up here, and the urethra, the tube you urinate through, goes down like this. All right, that's the tube you urinate through. The prostate is outlined in blue or lighter blue, and the seminal vesicle, which is a sister portion of the prostate to help make ejaculate, is right here in the darker blue. And then the prostate, this is the prostate. The colon is right here in this lighter kind of pink color. Now, you can see that the prostate is in the very middle of the pelvis. So you can see here, this is the pubic bone, this is the front part of the pelvis, and this is the sacrum, this is the back part of the pelvis. All right, so two important parts, and the prostate kind of sits right in the middle. Now, as we move over, I'm just going to use this kind of it's the same picture, but a little less going on. We'll talk about how we actually do the biopsy. So on the imaging that you have before the biopsy, there will be some kind of spot, or there will be a biomarker like a PSA or a urinary biomarker that's concerning, but there's nothing on the prostate. And so that gets into a little bit of how we do the biopsy from an imaging standpoint, which will be a separate video. But let's just talk about how we actually approach a spot. So there's two main options. Both of them have an ultrasound inside the prostate. Inside the rectum. So both of them have an ultrasound inside the rectum in order to visualize the prostate. Okay, so that's what we're doing. We're visualizing the prostate with the ultrasound. You can pass a needle alongside the ultrasound into the spot on the MRI, and that is called a transrectal approach because you're traversing the rectum, this portion right here. Okay. If you do a transrectal biopsy, obviously you need to be on antibiotics and you need to do a stool or a colon cleanse because there can be fecal material here and you don't want to translate that into the prostate. All right. You can also do a transperineal approach, and that's my personal preference. So with a transperineal approach, what we do is we first sterilize the skin. So we put alcohol right here to make it clear it of any bacteria. And then we do two things. First, we put anesthesia at the level of the skin right here. That's to keep you comfortable, and the soft tissue around the perineum, we numb that up. And then we put another block of anesthesia right here at the apex of the prostate. And that's also to keep your prostate numb while we're doing the procedure. It's very similar to a dentist procedure. This is a lidocaine where it blocks the nerve transmission to your brain so that you don't feel anything while we're doing the procedure. We then put an introductory needle in here. And the introductory needle is a bridge between the skin all the way to the prostate. There's a very, very, very low chance. It's about 1 in several million that we would seed back any cancer outside of the prostate. This would be like worrying about spread from the biopsy, but I still don't take any chances. So we do a Sellinger technique where we do an introductory needle. We then take a biopsy needle that goes through that introductory needle, take a sample of the lesion, and then bring the biopsy needle out through the bridging needle so that the tissue that we're sampling never touches anything around the prostate. So that is how the transperineal, now this is the perineum right here, we're traversing that perineum, so that's why it's called transperineal versus the transrectal approach. Now, in order to get this done, the most efficient method is to lay on your back with your feet elevated in the air. If I was to draw this picture like this, your prostate would be sitting right here, your bladder would be sitting right here, and then your urethra would be up like this, and you would elevate your scrotum and perineum, or sorry, your scrotum and phallus. You'd pull that up with your hands, which would then allow us access to a spot right here via this approach. Okay, so it's called the lithotomy position. It's the position, it's commonly known as a birthing position. If you have any loved ones who are females, they will recognize this as the way that cervical exams are commonly done, but it's a very efficient and comfortable method in order to do a transperineal prostate biopsy. So that's what you'll be expecting when you come into the clinic. Now, as I mentioned with the lidocaine, we will numb up the skin and numb up the prostate. Every man gets that. And most men rate their pain at about a 3 out of 10 on the pain scale. Sorry, 3 out of 10. There's some periods there where it's that's an average. So there's some periods where like we're inserting the lidocaine that's a little more intense, and some areas where once the lidocaine sets, it's a little less intense, but on average about a 3 out of 10. So not something you'd want to do on vacation, but very tolerable. For gentlemen who really say, I know myself, I'm a little bit more nervous about this procedure, I really want to make sure I'm as comfortable as possible, we do offer something called self-administered nitrous oxide. Okay, so this is an inhaled anesthetic and analgesic, meaning it calms you, but also decreases pain. And this is something where you just breathe it and you'll kind of feel light and floaty during the procedure. This is one of the studies that was published in our international journal showing efficacy. This gentleman, you'll notice, is on his side, not his back. That's because he was getting a transrectal procedure, so it works well for transrectal or transperineal. But this is the basics of it. So they took several men, they did a baseline pain survey, they got randomized between just oxygen or the nitrous oxide. Then they got split into those two groups, and they did a oxygen washout, meaning they just breathed oxygen at the end, and then did a post-survey to discuss their pain. The patients who got the self-adjusted anesthesia, which is this nitrous oxide, they did have increased comfort, and all of them were able to drive home. So this is something where you don't necessarily need a driver. You just need to let it metabolize, which happens after about 30, 40 minutes. Okay. So another option, one thing that's unfortunate is the insurance companies don't really care how comfortable you are. So we need to charge for the nitrous oxide in order to refill the tanks. But if it's something you're like, oh yeah, I would definitely want that, just let us know and we'll set you up. Finally, I want to talk about what you can expect after the procedure. Okay, so just a quick review. Here's the prostate, and we are going to put some alcohol along the skin in order to sterilize things. So you don't need to take antibiotics and you don't need to do an enema. We're then going to numb this tissue right here, and we're going to numb this tissue right here. And that's going to keep you comfortable during the procedure. We stick in an introductory needle, and that's to bridge the soft tissue up to the prostate. And then we're going to sample any areas on the prostate that are concerning. Now, when we sample this prostate lesion, and then we remove that needle, okay, so then that needle goes away, there's a little bit of blood around this area. And you'll remember also that seminal vesicle, which was right here, there can be a little bit of blood that goes into the seminal vesicle. Okay, it's not dangerous. It's like if you cut yourself on the arm, you'd put a tissue paper on there, and that tissue paper would absorb the blood, and then it would come up and it would scar. Well, the prostate, this blood will have compressive effects from the tissue around the prostate, but there will be blood in the ducts, which is the little architecture that usually bring sperm or ejaculate, the fluid that comes out with emission or orgasm, that will get stained red. And blood is very bright red. And then just as you get a bruise, right? If you get a bruise, it turns red, and then it turns like that dark, kind of almost purpley black color, and then it becomes green and then yellow. You'll see the same thing in your ejaculate, which is kind of unfortunate. but it's not dangerous. So there's no restrictions in activity as far as riding bikes, exercising, having sex, but it's just important to remember because it's kind of a turnoff if you're not expecting it. The other thing to remember is you're going to have a little bit of blood right here, and so that will get pushed out with urination. So for about 3 days, you can expect blood in the urine. Okay. And for about 20 ejaculates, sorry, the pen's not working. About 20 ejaculates to clear clear the blood from the prostate and seminal vesicles. So it can take a little while. It's again not dangerous, but you'll notice it's quite red at the beginning, then kind of becomes that darker color like you'd get a bruise, and then slowly fades away. So those are things you can expect. Another thing men want to know is, will it hurt after the biopsy? And thankfully, no. You'll be able to tell that you had a procedure, but you will not feel like you have a lot of pain down there after the lidocaine wears off. So I hope this is very helpful for you to understand what you can expect, how you can prepare. I take a lot of pride in making sure that we are very accurate, very safe, and then we give you the best diagnostic kind of results that you can hope for.